Muy buenos días y muy bienvenido al webinar.
Good morning and welcome to the PAH webinar for World Diabetes Day.
World Diabetes Day. This webinar will be in English and in Spanish. Este webinar será en español y en inglés. And we have simultaneous translation for you. At the bottom of the screen, you'll see a globe. And if you click on the interpretation globe, you can select the language of your choice. Así que yo soy Silvana Luciani. I'm Silvana Luciani from the NCD program here at the Pan American Health Organization, and I'm honored to join the International Diabetes Federation, WHO, and other organizations in this annual call for global action to prevent and control diabetes, a disease that affects millions of people worldwide. And this year, we are having a particularly important celebration as we commemorate 100 years since the discovery of insulin, a life-saving medication for many of those with diabetes. But we're also commemorating World Diabetes Day in the context of an extraordinary circumstances of the COVID-19 pandemic that continues to ravage most of our countries. So it's appropriate for this year that we celebrate World Diabetes Day with the theme of improving access to diabetes care. If not now, when? And so to deliver our message for this World Diabetes Day, we will hear from the PAHO Assistant Director, Dr. Jarvis Barbosa. Welcome, Dr. Barbosa.
Thank you, Silvana. Good morning. It's given me a great pleasure to open this webinar today to commemorate World Diabetes Day 2021 and to lend my support to this year's theme on increasing access to thank our partner, the International Diabetes Federation, for co-hosting this webinar with PAHO. We are all too aware that diabetes is a growing public health problem. Globally, the number of people with diabetes quadrupled in the past 40 years, and it is anticipated to affect more than 500 million people by 2030. In the Americas alone, 62 million people are living with diabetes, which is mainly type 2 diabetes, and over 340,000 people die from diabetes and related complications each year. The COVID-19 pandemic has worsened the situation as the public health measure and disruptions in essential health services have meant that people with diabetes might not be able to access the health care they need to optimally manage their condition. This year, as we celebrated the 100th anniversary as well as the basic technologies for diabetes management, such as blood glucose meters and test strips. Furthermore, many people with diabetes remain undiagnosed due to a limited access to primary care services for diabetes care. So we have still many people in our region that they have diabetes, but they don't have the access to primary health care in order to be diagnosed and to start receiving the treatment. So on this day, PAHO joins its partners to draw attention to governments and global health actors on the need to improve access to health services, medicines, and supplies for the diagnosis, treatment, and self-management of diabetes. These inputs are critical to control diabetes, prevent its complications, and improve the quality of life of people living with diabetes. Every country must ensure that diabetes care remains accessible and is incorporated as part of the primary care services network. This may mean offering care outside of traditional settings or relying on community health workers to conduct outreach services. In addition, insulin and other essential diabetes medicines must remain accessible and affordable to those who need them. In this regard, I want to urge governments to make use of PAHO's strategic fund, which offers high-quality diabetes medication at optimal prices, regardless of purchase size, because of its pooled regional procurement mechanism. Our health professionals must ensure that people with diabetes understand their risks and have access to the information and tools to manage and monitor their condition. To support these actions, the Global Diabetes Compact was launched by WHO earlier this year to unite the global health community to improve diabetes care. PAHO is committed to implement the Diabetes Compact in our region and to provide the technical cooperation to our member states. Please join us in raising awareness and in expanding diabetes diagnosis and treatment services as part of our efforts to build stronger and more resilient health systems in the Americas. Thank you for your attention, and let us now proceed with the World Diabetes Day webinar.
Excellent. Thank you very much, Dr. Barbosa, for this very inspiring message and for reminding us that diabetes services must be part of primary care services. And if you've just joined us, that was Dr. Jarvis Barbosa, the Assistant Director of the Pan American Health Organization, providing the opening remarks for our webinar on diabetes. And now we will turn to start our program, which includes an outstanding group of experts and practitioners from across the region who will talk to us about their experiences in improving access to diabetes in various contexts. But before we begin by going through the country experiences, we're going to start by first providing an overall context for diabetes in the entire region of the Americas. And for this, I'd like to invite our department director, Dr. Anselm Hennis, who leads the program on non-communicable diseases and mental health here at the Pan American Health Organization. Dr. Hennis, talk to us about diabetes situation and challenges and PAHO plans, please.
Good morning, all. Thank you so much for those kind words, Silvana, and welcome to World Diabetes Day and this webinar. So if you can put up the slides, Silvana, I think we can make a start. Thank you so much. Let's put it on slide presentation mode. It's still on. Wonderful, wonderful. So as we all know, diabetes is among the leading cause of death in the Americas, and it is actually the sixth leading cause of death, accounting for 20.9 per 100,000 in terms of the mortality rate in the Americas. Let's go to the next slide. Now, as we also know, and as Dr. Barbosa said, 62 million people have diabetes in the region, which is an overall regional prevalence of about 8.3%. It's important to note that the diabetes prevalence rates are highest in the Caribbean countries. And in fact, to really give a context, 9 of the 10 top countries which are listed with prevalent diabetes are in the English-speaking Caribbean, or 13 of the top 15 countries also are in the English-speaking Caribbean. So a small region with inordinately high rates of diabetes. Women are affected more than men. And also indigenous populations have about 2 to 3 times the rates of diabetes compared to general population in the United States. There are also other ethnic differences. For example, persons of South Asian descent in many of the populations, particularly in the Caribbean, have a predilection for having high rates of diabetes. Let's go to the next slide. Now, if we look at the trends in diabetes prevalence in the Americas, and in fact, the WHO Global Action Plan target is to halt the rise in diabetes, we can see from this slide that we are not on track and will not achieve this by 2025 in either gender. So we have a major challenge in our hands. Let's go to the next slide. So this is looking at global health estimates, and it speaks to changes in patterns of the major cause of years of life loss per 100,000 in the Americas. And in the year 2000, the age standardized rate of years of life loss ranked diabetes at number 10 with 520 per 100,000. 2 decades later, it's now ranked at number 8 with roughly 500 per 10 to the 1,000 years of life loss. And due to tremendous levels of disabilities and illness, diabetes is a leading cause of blindness, kidney failure, heart attacks, stroke, and lower limb amputation. And this situation has not improved with time. Let's go to the next slide. Now, why are we focusing on diabetes now? We heard already, and I'm going to say again and again, the growing epidemic of diabetes. 62 million people in the Americas live with diabetes, and as I said again, it's one of the leading causes of death. There's insufficient prevention. And in fact, when one does a comparison of all 6 WHO regions, the region of the Americas is the region which has the highest prevalence of overweight and obesity, as well as we are the global leader in terms of physical inactivity. They all go hand in hand. And these are drivers that tend to underpin our rates of diabetes. There's lack of diagnosis and management, again, as Dr. Barbosa said. Many people have diabetes and they're unaware or undiagnosed. And in fact, for example, in the US, as many as 1 in 3 adults, or 88 million people, have pre-diabetes and are not aware of it. So 50 to 70% of people who have diabetes do not have their blood sugar levels controlled. There's limited access to diabetes medicines and technologies, again, a point raised by Dr. Barbosa. And globally, 50% of persons with type 2 diabetes do not have access to insulin. In the Americas, the availability of essential diabetes medicines and technologies needs to be improved in the public sector. And I'm just going to draw your attention to a leader in this morning's Lancet, which is titled in the editorial, 100 Years of Insulin, a technical success but an access failure. And they speak to the fact that in spite of the gains in terms of treatments and so forth, access and cost tends to be a major barrier that continues to limit diabetes management and adequate access and care in this day and age. So these are major issues for us to tackle, and we've also heard about the WHO Global Diabetes Compact, which is now potentially proving a route and an opportunity through its bringing together private and public sectors to work on these 3 main areas: improving access to insulin and accompanying diabetes treatment products, building resilient health systems, and as well as involving those living with diabetes in the conversation as the way forward. Let's go to the next slide. Thank you. World Health Assembly Resolution of 2021, strengthening the prevention and control of diabetes, raises the priority given to diabetes within the non-communicable disease responses. It raises awareness about the burden of diabetes. It makes the case for including diabetes treatment and care in domestic COVID response and recovery plans. And as you've heard of the tremendous adverse impact of the pandemic on our health system services and the higher rates of complications, etc. And the need to strengthen health services for improved diabetes care. And as you can see, through prevention, early diagnosis, treatment and care, information, access to medicines and technologies, improved health management information systems, and equipping care through an adequate and well-trained workforce. Next slide, please. The new WHO report on insulin access speaks to limited availability. 3 multinational companies control more than 90% of the insulin market. Globally, half of people needing insulin for type 2 diabetes do not get it. And 60% of insulin availability is in Europe and the United States of America. But 75% of people with diabetes are outside of these areas. So right away, there's a geographical and geopolitical mismatch in terms of where of availability and need and access. Prices. In the United States of America, prices of insulin are 6 to 9.5 times higher than other high-income countries, which limits accessibility and availability. Quite often, you may have access to insulin, but you cannot have access to strips for monitoring. In Mexico, over half of annual household income goes to managing type 1 diabetes for the households which are so affected. Next slide. We have looked at the country capacity for diabetes control in the Americas. You can see the figures here. Over half have an operational diabetes action plan or strategy. Just fewer than a half of countries have national diabetes targets. Blood glucose measurement supplies are available in 94% of countries. HbA1c tests in 54%. And population surveys to measure diabetes in about 1/5. So we have some issues where we do well, essential managed medicines for diabetes available in 70% of countries, and guidelines exist also in about 74%. So you can see some of these gaps are tremendous and can be addressed and filled, but basically in sum, we have a long way to go. Next slide. So what is the global diabetes impact? As I said before in my brief introduction, it speaks to strengthening prevention and awareness through obesity prevention plans of action, information, education, communication, as well as mobilizing communities. Another pillar is diagnosis and treatment. And one of the very interesting opportunities is through the diabetes module of the HEARTS initiative, and I'm sure you know much about it. That's another conversation for another day. Also building capacity of providers. And as we said before, the PAHO Strategic Fund allows access to pool procurement for many of these medicines and technologies that can transform the way that we can provide access and care for diabetes. There's insulin, other medications, including sulfonylureas, as well as technologies such as glucometers. Monitoring, there are different mechanisms through, for example, population-wide step surveys and other health information systems. Next slide. These are, in the PAHO Strategic Fund, there currently exists these types of insulin, soluble, intermediate acting, as well as metformin and glycoside, but we have to really facilitate country uptake of these medications and expand the scope. There's just not enough uptake as yet, and the use of these PAHO Strategic Fund can result in tremendous cost savings and increased access, coupled with technical cooperation. Next slide. What's the way forward? We posit that an increased uptake of the PAHO Strategic Fund for Diabetes Medicines and Technologies would tremendously advance the access and reduce the treatment gaps in the region of the Americas. There's need to intensify advocacy and communications to raise diabetes awareness and to empower people living with diabetes who really must have a voice at the table in the planning and implementation and the monitoring and evaluation. There's need to scale up the implementation of diabetes prevention and control interventions in primary care through the HEARTS package as we strengthen the management and implementation and integration of non-communicable diseases in primary care. We must strengthen surveillance and information systems for diabetes to inform policies and practice, and also foster multi-stakeholder partnership in diabetes at the local, national, and regional levels. So really a lot to do. And I think at this point in time, Silvana, I hand back over to you.
Thank you very much, Dr. Hennis. That was Dr. Anselm Hennis, the Department Director for Non-Communicable Diseases and Mental Health at the Pan American Health Organization, giving us a tremendous overview of the diabetes situation in the Americas region and highlighting that while we're into 100 years of having insulin available, it's still a problem of access. And then, of course, also highlighting that it's not just having the medical technologies like medicine to be able to treat people with diabetes, but it's having that whole health service organization delivery to be able to have people diagnosed early and in time, receive the treatment, follow-up care that they need, and to be able to monitor and survey people and prevent complications from diabetes. And we know this is a tall order to ask of health systems, particularly at this time where COVID-19 continues to ravage most of our countries, and the priority for public health continues to be directed to COVID-19. But we know that many countries in our region have still continued to ensure essential services in primary care, tackling people with diabetes and addressing their needs has been part of the health system work. So here to showcase some of these experiences, we've invited some of our colleagues from the Ministries of Health. So we're going to start with our first country representative from Paraguay, and I'd like to invite Dr. Doris Roig, who is the director of the diabetes program in the Ministry of Health of Paraguay, to talk a little bit about her experiences. Doctora Roig, over to you. Doctora, no podemos escucharte. Tu micrófono está cerrado.
We cannot hear you, doctor. You're muted. Thank you very much. Thank you to the Pan American Health Organization. And well, in fact, I'll go directly to the point of how we created the steps for access to the care of diabetes in Paraguay. Paraguay has interesting characteristics regarding access. Mainly, we go to the presentation itself. And this has to do with what it meant, our history since 1994, when the history of Paraguay began. And it began with the National Diabetes Program from the Ministry of Public Health that was created in 1994, having a significant impact that this had in our country. Starting to work on this model of chronic care. I'd like to organize my presentation looking at it from the point of view of this model. We can not only see diabetes, but we see the patient in a comprehensive way with all the pathologies, chronic pathologies linked to this underlying pathologies. And in this model, and we've been following this for 5 years, dealing with a reality, and the most important thing that I'd like to share with you is the steps taken in order to access to the quality of services. And this is a very important point. And we'll stay here. Let me just show you this for a few minutes so that we can explain where we stand. We are undergoing a process of implementation. Paraguay has a 35% of coverage in primary health care, and that says a lot. And this 35% of coverage in primary health care means that this percentage can allow us to begin working in everything that it means. That is to say, transfer to the different levels, improving the quality of care and going to the next level of complexity, and to truly respect the portfolio of services for the first level. We have a guide, a management guide that has been negotiated with the entire scientific society, and irrespective of the management for diabetic type 1, type 2, pregnancy, and the management of the nutritional situation, it does have an important framework, which is the placement of patients. And I'd like to share with you what the impact meant in generating the classification of patients with diabetes. And having this score, the communities and the departments where we have 100%. In fact, is that we don't have one department with 100%, but we're approaching 100% of coverage in primary health care. And that enabled us, out of 1,200 patients that were being covered in the second and third level of complexity, patients and being classified based on their complexity, patients with diabetes type 1, diabetes in pregnancy, diabetes with a pregnancy, or diabetes type 2, complicated cases because of other complications or because of bad control or not following the treatment. These were patients that were left in the third level, and all the other patients that had low levels of complexity, a few years of evolution or treatment with oral medication, were kept in level 1. And this enabled us to organize and improve the assistance provided in the following level, the quality of the care. And therefore, in department where we had 1,200 patients, 200, which is at the second level, were distributed in the different health units, family health units, which is the name we give to the first level of care. Another point, next. This is the system, clinical information system. And we have some interesting steps here, and I believe that it is very important to share with you. Our national registry of patients with diabetes. Recently, we've made some headway in just a short period of time in formalizing our system, the electronic files. We currently have the following system, clinical information system, as I will show you now. It is the following. It is an information system where we have 1,600 health establishments, and only in 10% of these, since we're going to have a clinical information system, the clinical files, we're just starting with this. So what do we seek with this in order to create the registry? The information system is connected to the hospital system. And so we were able to generate in the IT system the function, the reporting function, and thus be able to notify our patients with diabetes, classifying them in the different levels, which is also a mandatory assignment. That is to say, patients at type 1 should be classified as AT, and patients at type 2, E11, in keeping with the international classification system. So what triggered or what led us to create this national coverage? Well, it also provided us with the possibility that not only the 1,700 establishments that are part of the public health system in Paraguay, but also the mixed systems such as the social system, clinical hospitals, polytechnic hospitals, and other establishments within the health system can register their patients with diabetes and thus be able to have information, valid information online. This is the progress that we've made. This is a recent resolution dated September 14, 2021. So we started with the 2 resolutions. This year was a year that triggered an institutional strengthening with these resolutions and with the creation of the National Registry of People with Diabetes in Paraguay through a single system, an IT system for the country. And as I was saying previously, you can join the system through the work modality. So we don't need to have the system in each one of our establishments, but we can use a user ID and a password, identify the patients that have been duly classified. And so this is the first data of what this national registry has meant. Since the National Police, through the ID number for our patients, we will be able to have access to georeference data, the address where they live, age, gender, the affiliation data for all our patients. And we have significant information now, which is the information that we had to understand clearly as to how many patients in Paraguay have diabetes type 1 and how many have diabetes type 2. What did we have as a basis? Well, we had a study and steps that was organized in 2011 in Paraguay that triggered a prevalence of 9.7% of diabetes type 2. And on the basis of that data, which is the only piece of information that we had, and we did not have clear information on the name and the last name of each one of the patients because we had different IT systems. And therefore, the patients came to the medical visit, and so they created several records. And so we have this information that has to do with the number of patients with diabetes type 1. And that triggered a huge impact on the budget that was terrible, because when we started seeing how many patients had diabetes type 1, it meant coded with MES. And so we had a number closer to 8,000 people. But in real life, our patients with diabetes type 1 in all health systems were 1,829 patients, as we currently have. And these 1,829 patients in all systems are diabetes type 1, which brings us closer to that incidence of diabetes type 1 of 1 per 100,000 inhabitants. So the first information that we're currently getting is the accurate number of patients and where they are located, these patients with diabetes type 1, based on the National Registry, which is a resolution that is already part of the country IT system. Type 2 is our major challenge. As I was saying, with a prevalence of 9.7, as you can imagine, is a huge challenge. What you see in red, what does this mean? In our country, we have 18 health divisions, I would say, by axis. We have these units. And like the prevalence study was done in all these years, we see the number of patients that we currently have been diagnosed in our system, and take a look at how we have a gap in access, a diagnosis gap that is around 80-90%. In the departments where we have a better coverage of primary health care, we still have a gap of 70% in the diagnosis. And the fact is that when we started doing this, we had not completed it. This is what we have in connection with what population do we have now. 9.7% has diabetes, patients older than 75. And currently, we see that we only have 61,000 patients. And this is only the public system. And this is how we bring in the other subsystems. But at our public system, we have, as people checking in 2020, in just 1 year, shows that we have 61,000 people. But if we have the prevalence of 9.7%, we still have 351,000 people left to be diagnosed or to have systematic medical visits. Many of them, because of the pandemic, never came back to see the physician because we had moments and times where we had close to 30,000 people that came back to their medical visits continuously. And this is where we had the data for 2020. But now we see a huge gap in our system, which really scared us when we started analyzing these numbers in a clear way related to the prevalence and access. Next, the interpreters apologize. There's a lot of echo, so we're trying to interpret what we hear. And so what to do? This is also something very interesting. What this will mean. This is very important. The previous one is how to have access to the National Registry of Diabetes Type 2, because as I was saying, 1,800, 1,900 patients with diabetes type 1 is not difficult to register. It's a small world. You bring them into the IT system, and we simply clean the quality of the data that has been entered. Now over 400,000 people, to bring them in with a national registry number, that's a different situation. So we see different modalities. These users have to go through our coordinators of chronic diseases in the health system and our primary health care physicians and the 857 family care units that we have in Paraguay, and we can start bringing them into the system. But since we only have 35% of primary health care coverage, then we have to bring in the remaining 65%. So it's still a significant percentage that has to be registered. With the pandemic, the Ministry of Health in Paraguay, and this is throughout the world, but in Paraguay, we saw a way of bringing these people with a free number that you can dial. And with just placing a call that was for free to the call center can lead you to self-registration. You can let us know that you have diabetes, and then through a telephone line, you can follow the self-registration process. We're just beginning this process with the two capitals, Asunción. We have millions of people living in Asunción, more than 4 million people living in Central. So this is a number of people that we will be registering with a modality through the call center. So it's a free way for them to bring in all these people to the National Registry of People with Diabetes. Next. Another one of the important points that I wanted to share with you with this peculiarity in Paraguay has to do with the model of chronic care, and it is the support to self-management. This support of self-management has been standardized in these notebooks with our patients, my notebook, my health notebook, and it allows the patients to have some sort of an electronic e-file, portable e-file, when we still don't have 100% an automated system, because as soon as we have an electronic file in all our systems, it will no longer be necessary to have health and notebooks because the information will be in the IT system. But this is important because it's a characteristic of migrating from one service to the other one, and for the clinical information of the patient to be kept up to date. This is typical in our case, and we're now able to standardize and to truly have it as a unique condition for all our patients. Next. Okay. Let me stress that the issue of insulin in Paraguay. There's a very important situation because it's part of our history, because 100 years ago, when insulin was discovered for Paraguay, we started having insulin in 1997. In 1994, the program was created, but we did not have the budget with Congress. And recently, in 1996, we had a budget of $400,000 that was assigned to this. And therefore, the pharmaceutical industry started importing, and then the government said Paraguay should have insulin. And the one who has insulin available in the market and making it accessible in the public health system in Paraguay, that started in 1997. And this budget had a significant impact because even went up to $19 million a year until a law was enacted. And this is a very important law in our country, comprehensive care for people with diabetes, enacted in 2003, but then amended in 2014. And it simply enacted the law from $400,000 that we had initially, and then going up to $19 billion. Currently, it went up to $34 million. $34 million, which is what we currently have budgeted for close to 80,000 people, in fact, that are having access to the best service. All our patients with diabetes type 1, 1,800 patients that I told you, have ultra-slow insulin, ultra-fast, with all the necessary measures. And our patients type 2, where we still need 20% to receive insulin of patients with type 2 diabetes. And there's a lot of work to be done, but it has to do with the 35% of coverage in primary health care. So that is where we are.
But the impact of that law in 2014 meant that there we had a budget close to $34 million. Now we have different modalities, and all of this has to do with sustainability, the public system that has medication. So with these steps, in terms of the model created together, but with some steps, and some people have a gloomy outlook, but when you see that we have taken steps within a framework of coordinated chronic care, we have an information system where we do have data now, and when by 2022 we will have more information about patients with diabetes 1 and diabetes 2. So look at the different cases, and we will continue to move ahead with clear information, and that will bring us to the end of our first study of patients with diabetes type 2. And also here we will look at the indications as a part of our primary health care. Thank you. Thank you. Thank you, Dr. Roy. And thank you for putting right in the middle of all the efforts people who live with diabetes. And also, I congratulate you on the innovation, the registry, the use of cell phones to register people, because it's important to find who the people with diabetes are. And in that way, we can improve the quality of care to serve those needs. So thank you. Thank you for being with us. Thank you for sharing Paraguay's experience.
Gracias. Now we will move to Trinidad and Tobago, and I would like to invite Dr. Abdul Hamid, who is the General Manager for Primary Care in the North Central Regional Health Authority from Trinidad and Tobago, to talk to us about how they've been managing, especially at this time of COVID-19, to serve the needs of people living with diabetes. Over to you, Dr. Hamid.
Good morning.
Good morning.
All right. Good morning. Buenos dias. Bonjour. Bom dia. So it is my absolute pleasure to speak to you today in commemoration of World Diabetes Day. And the theme this year, of course, is the access to diabetes care. So throughout the world, as we know, and we've been saying over and over again here, there are millions of people who are unable to access the appropriate care for diabetes. Diabetes requires simple, appropriate, timely, adequate, and sustained care to manage the condition and to avoid complications. I present to you today the experience of Trinidad and Tobago and how multiple dimensional solutions can facilitate appropriate access to care.
Sonia? Oh, okay.
Right. So our country presentation, Increasing Access to Diabetes Care, outlined. So the overview of Trinidad and Tobago, diabetes prevalence, our national strategies, and our RHA specific strategies, COVID-19 and diabetes, and lessons learned and conclusion. If you notice on the map there, we are the southernmost Caribbean nation, English-speaking island. And if you notice on the map on the left-hand side, that is the tip of South America, which is Venezuela. So we are literally on the edge of the South American continent. It's a twin island republic. It's the most industrialized island in the Caribbean. Population 1.34 million. Male to female ratio of 1:1. Very, very diverse population in terms of ethnicity, religion, and culture. And it's recognized by the World Bank as a higher income economy. So our health system is guided by the Ministry of Health, and that the Ministry of Health provides leadership, governance, set policies, legislation, goals, and targets. And in our small twin island country, we have 5 regional health authorities, and they are all semi-autonomous bodies for delivery of services. They are known as Northwest Regional Health Authority, North Central Regional Health Authority, Eastern Regional Health Authority, Southwest Regional Health Authority, Tobago Regional Health Authority, and they are all defined on geographical boundaries. They are semi-autonomous, meaning that each one can develop customized approaches or initiatives, which are eventually replicated at best standard across the board. We in Trinidad and Tobago have free healthcare service for every single citizen. We have a network of 98 health centers and 7 district health facilities, 8 hospitals, and all regional health authorities have at least 1 district health facility and 1 referral hospital. So as mentioned before, Trinidad is no exception, and it has one of the highest prevalence of diabetes in the Caribbean. Some sources estimate we have at least 102,000 to 145,000 diabetics. The adult population in Trinidad and Tobago is 982,000. We're looking at a potential cases of 121,300 diabetics. And based on the PAHO NC at a glance report, the death rate is amongst the highest, which is about 115 per 100,000 persons in Trinidad and Tobago. So we do have a very serious situation here. The diabetes prevalence in Trinidad and Tobago compared to the world and North America and the Caribbean, it's quite high amongst and across the age groups, as you can see. So given that backdrop of what we are facing and echo the previous speakers before, we in the Caribbean and Trinidad and Tobago, we have developed and had the privilege to develop certain country strategies, of course, guided by international best standards. And I was very pleased to hear it mentioned here in the symposium so far of the HEARTS D package. This has been adopted by Trinidad and Tobago Ministry of Health since September 2020. And in a similar manner to hypertension, what our approach is in terms of the HEARTS D package would be to harmonize it with the latest protocols that we have and standardized management of diabetics or diabetes, thus ensuring diabetics get standard treatment whatever site they visit. It was piloted with Tobago Regional Health Authority, and it has been in the process of being adopted at that RHA as well as the North Central Regional Health Authority and the other RHAs. Now, what is important about this, the HEARTS D package, and I think one of the reasons why we have been successful, especially with the very quick adoption of the HEARTS initiative and integration into our healthcare system, the HEARTS D package has been quite well received across the board. So our strategic intention, it's been done by a process of dissemination into clinical areas, followed by field discussions and eventual implementation across the board. Next strategy, and this was done since 2018, it's the Diabetes and Pregnancy Guidelines. So it's a major program launched in 2018 under the Directorate of Women's Health, and it standardizes the screening. It standardizes the screening of all women for gestational diabetes and provides follow-up care and management of women to prevent or control gestational diabetes. So this is one of in a similar vein, it gives a standardized routine and universal approach to screening of all antenatal patients for hyperglycemia in pregnancy and a standardized management across the board. And this is one of the important points of access to care. So not just access to care, but access to standardized care across the country. The diabetic retinopathy screening services was piloted at one of the Southwest Regional Health Authority for the past 7 years. As such, the Ministry of Health and PAHO has been implementing it across each RHA throughout Trinidad and Tobago. It is one of those initiatives that removes or takes away from tertiary care the patient having to go to tertiary care services rather than visit the primary care services to get basic screening for retinopathy. And it's been done by non-specialized retinal photography and grading. This, in effect, has reduced number of patients at tertiary ophthalmology clinics and facilitates primary care, patients in primary care getting early and easier access to appropriate retinopathy screening. As a national program, and this was done in 2017, and as a start to a national ban on sugar intake in adults on guidelines to reduce sugar intake in adults and children, based on the WHO guidelines, there was a ban on sugary drinks in schools starting from 2017. This is in effect given that we have, as mentioned before, Trinidad and Tobago and the Caribbean has one of the highest obesity rates in the world. And we are, with the data, we are well aware that the obesity does not just start in adulthood, but it starts at the children and the teenage levels in schools. Now, this is the Chronic Disease Assistance Program, or CDAP. It's one of our long-standing in Trinidad and Tobago access to medications. And this is a free prescription drugs program. It was established in 2003. It has an expanding distribution network of prescription drugs and medical supplies via over 200 private contracted pharmacies. This ensures true universal access to medication. So literally, citizens can access within almost walking distance a point to get medications which are free. All citizens with NCDs are eligible regardless of age, income, or other socioeconomic factors. And coverage for 12 chronic disease conditions with 47 core essential medications. Now, very important, and in the gist of our presentation here today, in that same program, one of the initial parts of the program was to supply insulin needles, oral diabetic medications, and free glucometers and strips to all diabetics in Trinidad and Tobago. And no co-payments or contribution will have been ever required by beneficiaries. In line with further community support, the Chronic Disease Self-Management Program, which seeks to empower people with NCDs to make healthier lifestyle choices and better manage their own chronic conditions. So basically, the program is to help persons develop knowledge, skills, and confidence to care for themselves and manage their condition effectively. One of the points about this program really is to have a motivated patient who has self-ownership of their health rather than reliance on the healthcare system. It is considered a key aspect of the chronic care model, and it's based on self-management and peer management. It's linked to the formal health system through established chronic disease patient support groups. And the training of lead trainers completed in June 2021, and rollout in communities started in September 2021. 72 persons to be trained by December 2021 with 6 weeks program done via Zoom in groups of 12. Multi-sectorial collaboration, and this is all in the theme of increased collaboration between the healthcare system and the public civil society. So it's the participation of civil society into the healthcare system, and it allows us to catalyze the development of healthy public policies. For example, the Diabetes Association of Trinidad and Tobago implemented a diabetes education program for primary school students. The TNT NCD Alliance facilitates greater participation by civil society sector in taking actions to reduce the burden of NCDs in the population. And they all help to increase our screening in the public sector and in the population. Plus, we have formal partnership with faith-based organizations such as the North Central Regional Health Authority, Walk the Talk Faith-Based Organization Partnership, which seeks to both highlight healthy practices and screening in the public setting. The aim really of the healthcare system is to blur the line between the healthcare system and communities, and empowerment of communities and advocates in our communities. So here I present some of our NCRHA diabetes programs. The first major program that we have is the Diabetes Wellness Center. Now, it may seem an interesting concept to involve a tertiary care system into a primary care system. But the whole point of it is to have an innovative one-stop shop solution to bring high quality and cost-effective healthcare to treat and minimize the effects of diabetes. At that first visit, it may also be the only visit. Medical care, lab tests, pharmacy, wound care, endocrinology, nephrology, diabetic education, and ophthalmology are all done on the same patient on the same day. The whole point of it is to have a fully packaged patient, either a newly diagnosed diabetic or an uncontrolled diabetic, to have a full gamut of services to be stabilized and sent back to primary care for follow-up. It is not meant to be a regular chronic disease clinic. The whole point of it is to fast-track certain tests and assessments backwards into primary care. The other point of it is to have, now, most of the time when a diabetic is newly diagnosed, certain tests and certain assessments could take months, could take years in the regular system. So this whole program really fast tracks the patient and provides a very well-controlled patient and a motivated patient so that we will prevent any further complications. The wound care clinic in primary care, which really is increased access to timely wound assessment and podiatric service for diabetics. Traditionally, wound care clinics were, number one, not very specialized, routine, just change of dressings, and referral to hospital for further management of wounds. However, what we discovered, because of the situation in primary care and the ease of access to specialized wound care, it was realized that a wound care clinic in primary care with specialist level clinic staff would be a necessity. And we have seen potentially less amputations due to proper and timely wound care by expert nursing personnel. The diabetes support group, it's one of the important things of our diabetes or any support group is to have that buy-in by peers in the group itself. And it creates an environment where clients are equipped with the knowledge and skills necessary to make informed decisions in the management of their diabetes in an effort to achieve and maintain control of their glucose levels. So what you're in fact creating is a self-managed patient. These groups are administered by diabetic nurse educators and managed by patients. It's also our main source of motivated patients who are being trained as self-management champions and community advocates. And this is where we will get the buy-in from the public. COVID-19 and diabetes. So one of the problems, as we all have faced in the beginning of the pandemic, the first thing that happened was a complete access block. So we had problems with delivery access, efficiency, and continuity in the face of the pandemic. The very high risk, especially diabetics, suffer from poor outcomes, but they're even higher risk by being exposed to more crowded clinics, limited access to medications, limited access to consultations. So telemedicine, as in eventually the rest of the Caribbean and the world, was piloted in some of our chronic disease clinics. And it started off quite basic with just a phone call, followed by a complete comprehensive consultation, counseling, renewal of prescriptions, and a special system whereby prescriptions were fully packaged and delivered to patients. So lessons learned and conclusion. So it is critical for universal clinical management approach. It is critical for a unified approach amongst all healthcare workers, amongst all primary care physicians, literally given the same message, treating the patients similarly with the same protocols and having the same standards of care across the board. There must be a recognition that the whole of society approach is vital with a very strong community partnership. And as I mentioned, blurring that line between healthcare, formal healthcare, and the communities. And most important, continued access to appropriate care despite challenges of the COVID-19 pandemic. I thank you so much. These are some scenes of my country, Trinidad and Tobago.
Wonderful. Thank you very much, Dr. Hamid. And congratulations on having such a very comprehensive program that addresses primary prevention of type 2 diabetes and prevention of complications from uncontrolled diabetes, to having a very complete wellness clinic for people and standardization of care through guidelines that are applied across all the regional health authorities. And also on telemedicine, which I think is the way of the future, right, to ensure continuity as we face health outbreaks. And so thank you again for sharing your insights and experiences. And we're going to move now to the panel of our partners from the International Diabetes Federation. And I'm really pleased that we have the regional chairs from our region who are going to talk about civil society perspectives on improving access to diabetes and engaging more closely with communities and people living with diabetes. So I'd like to invite our next speaker, Dr. Douglas Villarreal, who is the regional chair for South and Central America on increasing access to care for indigenous communities in Bolivia. He will present in Spanish, and just to remind everybody that there is simultaneous interpretation at the bottom with the interpretation globe at the bottom. Over to you, Douglas.
Muchas gracias. Quiero hacer un agradecimiento.
Thank you very much. I'd like to address my special gratitude to Silvana Luciani and to Beatriz Yanez for the extraordinary work they're doing. And together with that entire wonderful team of APAHO and IDF for the joint work that both organizations do in that attempt to raise the voice of diabetes and to expand our actions jointly. So thank you very much, Silvana, for all the work you do.
Bueno, vamos a empezar a comenzar.
Very well. Let's begin talking about a very specific case that has to do with access to diabetes care in an indigenous community in Bolivia. The medical center, Susan Ho, is located in Palacios, Bolivia, 110 kilometers away from the city of Santa Cruz de la Sierra. It was founded thanks to the initiatives and the contributions made by Dr. Susan Ho, who passed away a couple of years ago, and yours truly. It works in rural communities with indigenous communities. The medical center of Palacios is located in Santa Cruz de la Sierra in the Amazon region. And if you see, take a look at the map, you have La Paz, the Titicaca Lake, and Machu Picchu in Peru. Bolivia has 4 different contrasting heights. We have El Alto, 4,500 meters in height. And then we start coming down to La Paz to 3,695 meters. Cochabamba, that is even further down, 1,500 meters. And then Santa Cruz, 437 meters above sea level. So this is where we find our center that works with indigenous communities. Next. In the only prevalence of diabetes study that was performed in 1998 with the support precisely offered by the Pan American Health Organization, we see that the prevalence of diabetes in Bolivia was of 7.2%. And that as we started coming down from the heights to the prairies, the prevalence of diabetes has started increasing from 2.7% to 10.7% in Santa Cruz. Next. The Susan Hose Medical Center provides primary health care to people from indigenous communities that are living in the Bolivian tropical forest, 120 kilometers away from the city of Santa Cruz. It is quality care provided for acute and chronic diseases, especially emphasizing diabetes, hypertension, and overweight. It helps community people in acknowledging, recognizing, and eliminating the main causes of their diseases. Next. These diseases and tropical infections are as common as we see in the medical center. And amongst these, we have malnutrition, we have infections caused by worms, by parasites, and of all infections, those that are most common are Chagas disease, malaria, dengue, yellow fever, leishmaniasis, TB, and HIV, which are very prevalent from what we see at the center. And as I was saying, the clinic is located far away from the city of Santa Cruz de la Sierra, and most of the road is paved, but the last 10 kilometers, where everybody knows this as the ugly road, because when it rains, it is very difficult to have access because we're in the middle of a place where we have our own satellite internet, our own water system, our own cable. In order to have electric power, we have a well so that we can get water because it doesn't reach that place. And we take care of 14 indigenous or rural communities. And it is difficult to get there, but we help with the transportation that we offer to the communities. Sometimes physicians have to get their own food for dinner. Here we see Dr. Michael Langarone from the University of Northwestern in Chicago when he came to support our center, and along the way he found this armadillo that is commonly called tatu. Next. At the medical center, we administer vaccines to children. We take care of communities that are further north from the center where there's a lot of immigration. We take care of chronic diseases such as arthritis or lesions in the legs that are caused by neuropathies and diabetic neuropathy. Next. The equipment and the team, we have data entry, we have access to electronic and medical systems, we have the pharmacy, the lab, we have dental service, ophthalmology with a special lamp, and we read x-rays. We use the windows, which is equally efficient by reading the x-rays on the windows. And let us recall that all of this is done in rural communities. We have a clinic that is quite remote from the populations. We see the paradox of nutrition where there's low weight and at the same time obesity. So this means that cheap food with hypercaloric, very low nutrients that affect the growth or stunt the growth of children. And therefore, with so many calories, it leads them to overweight. When they're consuming excess calories, it leads to overweight. When in the past they had low weight, and that is as a reaction by the body in saving calories because they had a shortage of these. So managing diabetes, and this is in a rural community, the Amazon region. Obviously, it is quite different than in any health center that has the conditions that we see in the city. The main objectives is to have glucose levels, sugar levels, to be as close as possible to what is normal, that we don't have low levels of sugar. And with all of this, we try to reduce complications, both microvascular, neurological, and macrovascular of diabetes. 98% of people who have diabetes is type 2. And the care we provide is focused on primary health care and then secondary intervention. And we have a limited capacity to perform tertiary interventions. For example, when someone has a heart attack or a stroke. The next one. Managing diabetes from the point of view of primary prevention is concentrated on the change in lifestyles, promoting exercise, healthy food, nutrition. But the question that we always ask ourselves is how to implement this in large scale. And we see that the culture of many rural communities emphasizes less healthy habits, where people eat food with fat and high carbohydrates, and likewise exercising on a regular basis is less common in rural communities, particularly in the smaller communities. Next. There's a greater emphasis in enjoying things like food than thinking about the consequences for health or on health 10 years from now. A lot of people in the communities that we cover do not have easy access to fresh food. And this happens in spite of the fact that agriculture is part of the activities, the working activities of all those areas. The lack of education is more common in most of the people living in these 14 rural communities that we cover. And we know that without adequate education on health in general, obviously leads to not very healthy habits. And that is why we greatly emphasize education. And in spite of the fact that field work is hard, we see that people do very little or none physical activity or exercising proper. We have programs that we develop in each rural community, and one of them is community programs for physical activity, doing or promoting what they like doing. In this case, for example, is dancing, typical dancing in each community. It is a very nice and interesting way to be able to promote the physical activity in the communities. The availability of drugs in Bolivia, we don't have many options for medicines that what we use, and this is the main thing that we use is a metformin. We also have available sulfonylureas, particularly glypsicide, glibenclamide, and also the thiazolidinodones and inhibitors, DPP-4. We have them in Bolivia, but they're expensive. We cannot resort to that to offer these to the communities because we provide the medicines in a free way, or in some cases with a very low price. GLP-1 agonists are not available. Inhibitors, SGLT2, which are so good for people with diabetes, are not available. We have insulin, regular, Glargine, Apidra in Bolivia, but obviously those we use are lower cost, which is NPH and regular. Next. Regarding managing diabetes in secondary intervention, the control of leukemia is the basis. The drugs that we use, as I was saying, is these that you can see on the screen. And insulin, we provide and we supply insulin, but in fact, it is very difficult to manage it. because it is necessary, and many a times that they don't have where to put them in a cool area. So what we want is to have a community refrigerator. Then many a times that they're not very healthy conditions for injections. Many houses have land, don't have concrete floors. So people come to the center to measure the glycemia by measuring their blood pressure. And many times the control at home is not realistic because the devices are not good. They're not working well. They don't have sufficient reagents. Sometimes we give them away. Sometimes we don't. But the measurement of hemoglobin A1C is done when we have the reagents. The DCA 2000 that we have in our labs are expensive, so we cannot use this with everyone. And we adjust treatments in order to reach a minimum of 8 in HbA1c, knowing that the ideal situation is to have less than 7. But it is difficult to do it. I must accept that. Now, regarding a secondary intervention, what do we do so as not to end up with an amputation? Well, control of glycemia, that's a basis. And also the exam or the test of loss of sensitivity, vibration, monofilament, the prevention of wounds. We insist on them using shoes, not sandals, not flip-flops, not to go barefoot. And we try to have them use shoes not very tight and not very big. And so when they come with ulcers or blisters on the foot, we always try to have a conservative treatment because later on they will not have the resources if they end up with an amputation, and then their life will be extremely difficult. Now, regarding the damage of diabetes on the eyes, controlling glycemia, we have provision of glasses that is provided by the Lions Club many a times, and we cannot do laser photocoagulation because we do not have that procedure. We don't have that procedure in the rural communities. You need to come to a big city. Next.
Tampoco hay endocrinólogos en las áreas rurales, entonces muchas veces quienes toman su lugar.
We don't have endocrinologists in the rural areas either. So often it's a shaman that takes over. Sometimes they do a good job. We even did a study of the most common plants that they use to treat different diseases, especially the chronic ones, to understand the indigenous communities and see what they see the treatment should be. But then we see complications because of a lack of care.
Y la falta de educación,
and that lack of education, the lack of access to medical care, the fact that there are no endocrinologists means that many of the complications advance. There aren't specialists in diabetes. There is no general access to care. And so we see the complications of diabetes and the cost of care if they go to a medical center is something they cannot afford. It's not free of charge. We do not charge, but other centers do. So poorly managed diabetes can lead to serious complications. And in most rural communities, they are not prepared to deal with this. The diabetic foot is one of the complications. And this progresses more and more because they have no feeling. It doesn't hurt. So here we would have to change lifestyles, and this has to be effective. So they don't need such expensive medications to prevent diabetes or to deal with its complications. So our first effort in these rural communities has to be to educate and educate some more. And we try to educate the people that are political capacities in these areas. They have to learn to interact with these rural communities. 2 more minutes, please. Thank you, Silvana. So what are the conceptual barriers? What stands in the way of long-term care? Well, first of all, people have to understand what it means to have a chronic disease. We know that the concerns in the short term are often overwhelming, It's really hard to think of the long term. It is necessary to have ongoing controls, receiving medication. Also, they are often too poor to buy medication, and there's a lack of transportation. And we have 3 steps that we implement. First of all, we study the barriers that stand in the way of long-term treatment. We establish long-term programs in communities, and we detect and overcome other practical barriers to care. We do verbal surveys of communities to understand what a long-term disease means to them. What treatment are they following? Have they changed their lifestyle? We develop programs having to do with management. In other words, we identify people that are volunteers. We train them so that they can manage diabetes effectively. In the communities, they measure sugar levels, hypertension. We also teach how to adjust treatment. We partner with communities. We provide information, and when that training concludes, we issue certificates. We provide medicine free of charge for a quarter or for a month. We keep the patient under direct observation. We have a network of volunteers in the community. We collaborate instead of competing with local care providers. We localize and facilitate medical care when necessary. And here the question is, where is your refrigerator to store your insulin? You have to realize that we have temperatures between 35 and 40 degrees centigrade in the hot months. And I'm just about to conclude. In conclusion, it is essential to partner with local care providers. The logistics for building and establishing a clinic requires perseverance and money. You need a permanent base for operations to deal with chronic diseases like diabetes, and you have to overcome local, policy, community, and personal barriers in order to provide care. That is wonderful. And the slide says she makes it all worthwhile. Thank you. Thank you very much, Doctor. Thank you, Dr. Villarroel, for emphasizing how important it is to reach the community, to work the communities, especially in areas where they are isolated and where they have no access to services. So thank you on your great work and all of your accomplishments. We're going to be sharing that experience so as to thus expand access to essential services.
So I thank everybody for their patience. We have one last presenter because we want to kind of round this off with the regional perspective and sub-regional perspective. So we're going to invite now the regional chair for North America and the Caribbean of the International Diabetes Federation, and that's Dr. Timothy Dorr, who's going to talk to us about increasing access to diabetes care in the Caribbean. So over to you, Dr. Tim.
Thank you very much. I was diagnosed with type 1 diabetes over 30 years ago in Mexico City. I was 7 years old. I'd been feeling unwell for about a month. I was losing weight, drinking a lot of water. My vision was blurry. I lacked energy and I didn't want to play. As I'd always been extremely active and alert, my parents knew immediately that something was wrong. They took me to my pediatrician and then different hospitals where I was prescribed treatments, but I did not get any better. My health deteriorated until one morning, I felt strong abdominal pain and could not raise my head or even open my eyes. I was taken back to the hospital where no one knew what was wrong. One of the doctors noticed a fruity odor on my breath. He asked my parents for permission to run a blood glucose test. I remember being out on an IV drip. I felt really tired and confused. I fell asleep. 5 days later, I woke up. Then a few weeks later, I was able to go home, but my life had changed. It was totally different. In Mexico, all people with diabetes have had issues accessing insulin at some point. Insulin is perhaps cheaper than in other countries, but only around 1 in 3 Mexicans with diabetes earn enough to afford everything required to manage their condition. My lowest point was when my husband and I had to decide whether to buy glucose strips or food. Right. This was a testimonial from our very own Mariana Gomez from Mexico. There are many more testimonials like this about the life experience of people living with diabetes within our region. Our region is represented by only 23 countries. And I am Timothy Astor. I am a family physician, but I'm also the North American and Caribbean Regional Chair for IDF. And I will attempt to provide you with an idea of the experiences of persons living with diabetes here in our region, but in particular looking at emphasis on access to diabetes care. Let me first present to you for the first time the data from our Atlas Committee from IDF, statistics on diabetes within our region for 2021. So this is information that has just come out. It's hot off the press, so you're the first ones to see it. Congratulations. I'm going to attempt to show you the information and then make a few deductions. All right. Now, as I looked at the data, which you will get because it will be available online, there are some major points that immediately jumped at me when I looked at that information. First, our region has 361 million people living with diabetes. Okay, all right. The number is expected to increase in the next 25 years. Approximately 12.2 million people between the ages of 20 to 79 living with diabetes are undiagnosed. There are 192,500 children between the ages of 0 to 19 living with type 1 diabetes, and 24,400 are newly diagnosed each year. Now, this figure was from 2021. The total healthcare expenditure on diabetes for persons between ages 20 to 79 for 2021 was $414.6 billion US. That's in our region. It's not just St. Lucia. So I don't think we have that much money anyway. The top 5 countries with the highest number of persons living with diabetes: USA, Mexico, Canada, Haiti, and Jamaica. I must declare, though, that I may not be in a position to explain all the data, but for those of you who like statistics and who like to look at information like this, you might agree with me when I say that this is very interesting. I'm pretty sure that the IDF Atlas Committee would be happy to speak to anybody who wants to get some further specifics on the data. So I'll get back to our testimonials, and I want you to take note that while the experiences of persons living with diabetes in just one country may vary based on maybe that person's economic background, maybe their location in the country, their education, it also varies widely from country to country. And the country's resources could also be permissive or restricted. This may in some way tie in with maybe the classification of developed and developing countries, possibly. There's a lot of economics with this. But in the NAC region, there is such diversity. And it would be very difficult for me to give you a general perspective of how access to diabetes care supplies and medication has really changed any specific community. But I did, in preparation for this presentation, do quite a few interviews and did some research. So I was able to compile the following about the availability in general of resources. Now, what I'm presenting to you may be completely free, may be subsidized, or may be paid completely by either an NGO or the government. Centers located within the communities, and as Dr. Via Worrell presented before, she showed you that they have these clinics that are far into the community, into the distant communities that are far from the city. So that's something that most countries try to provide: general medical clinics, specialty clinics, especially with endocrinology and food care, or another specialty, whichever is available in the country. Some countries don't have endocrinology, some do. There's the daily or weekly operation of those clinics, which allows for patients to get the care they need: nutritionist services, family nurse practitioner services, general nursing services, primary, secondary care services, access to medication testing supplies, and access to education materials and other helpful resources. Right? So all of these things are things that have been done, and the presenters before have given you a good idea of those things that are available, the great work that they've been doing to get the patients the medication and the education that they need. In some of those primary care services, you may have a few other things that are available. For instance, blood sugar and pressure testing as requested, laboratory screening, and that would include screening for your kidney function, liver function, lipid profile, the HbA1c, whatever is necessary. I'm hoping you can hear me. I saw you lean forward. All right. Diabetic retinopathy screening, podiatry visits, general medical clinics, dentistry visits, dermatology consultations, diabetes and hypertension clinics, and self-management through courses, for example, Stanford, which Paho has provided. Of course, there are many others, but we have improved. And I can tell you, there's evidence. We've been doing a lot of work, not just Paho. There's ADA, the individual organizations in the different countries. We've all been doing quite a bit of work. And this is the fruit of our labor. You see all of this, right? But then you still hear the statistics that we have 361 million people living with diabetes, and the numbers are tending to increase, right? So we do have a problem on our hands. So, right. A patient from one of the Caribbean countries actually shared this testimonial with me. In his 30 years of living with diabetes, he felt satisfied that medication, insulin, doctor's visits, the laboratory tests for screening, all that I mentioned, and management were all free. That's right, FREE. That's something that when you hear that, you wonder, oh, how is that possible? Right? And all patients who got that got it through a public government clinic. Right, so you have St. Kitts and Nevis that's offering something like that. St. Lucia, St. Vincent, Grenada, Trinidad just spoke about it. So you'd find that all the countries, they're trying to adopt a model, right? And we can all understand it. This is similar to the intention that we want, which is to provide that universal health care, right? And that is certainly there. But he also confirmed another thing, that the free service was reliable. He said reliable, and the supplies were available more than 90% of the time. He couldn't say 100%, being realistic. But please remember this little fact as I continue the presentation. So, in putting all of this information together and speaking to all of these people across our region, our 23 different countries, there's some things we could say that are common based on the work. that we've been doing. There's an increased awareness of diabetes and its effects. Yeah, that is obvious. A lot more people know about it. A lot more people are testing, right? There is an improved quality of the self-management. A lot more people are aware of the targets and are trying to achieve those targets. So you know you're doing something good. People understand its importance, and they're willing to engage in the activities that are necessary for their own well-being. That's good. There's also an increase in the number of people who access the services. So you do have that demand growing. Yeah, so the awareness is building. Maybe we still have some ways to go, but our work is not all for nothing, right? It's not all in vain. But there are some challenges. And the challenges that I present are based on my analysis. The first one is about quality versus equity. Are you able to provide the same services to everybody? Are you willing to provide the same services to everybody? And what are the consequences? Are there people who are disadvantaged? Or are you going to try to make it equitable, where everybody receives a service where they could reach? You understand? Everybody's different. And there's another one, and this is possibly my favorite one to explain. Sustainability. Is it sustainable? Can you sustain what you're doing right now? 10 years down the line, 20 years down the line. A lot of our countries, we complain that when international organizations come in, they do a whole lot of analysis. They take data, they have you running around for weeks, and then they leave. And then what? They come the next year or 10 years later, do the same thing. What are we doing for sustainability? Or maybe our governments might decide to be proactive and do something and offer everything for free. And then they can't afford to buy food, or they can't afford to sustain other aspects of the economy. Is it sustainable? There's a lot. I don't have the answer for that, but I'm just throwing this out there. So based on those two challenges, I was able to find a few pitfalls in our access to diabetes care. Right. The first one is finance. In a paper published by Matthew C. Riddle and William H. Herman by the ADA, and that paper was called The Cost of Diabetes Care, the elephant in the room. There they described that for a long time, nobody wanted to speak about finance because they were kind of, feeling, let's just leave it alone. But it's impossible to ignore it right now because the elephant has grown so big that you literally can't be in the room anymore. All right, so they eloquently spoke about the issue in that article. And they summarized the cost of diabetes present large problems to patients and their families and to health systems, insurers, and the entire community. These problems are not yet coming under control, but scientific studies reported in diabetes care and elsewhere are beginning to clarify how best to limit the complications of diabetes, while both containing costs and avoiding unintended harms. This balancing act of sustainability and equity is truly difficult, I can see. And that would be the case for any country, whether you developed or developing, doesn't matter. So it appears almost impossible, as some may adopt a model which may be sustainable, and some may adopt a model which may be more equitable, while some provide equity, but it's not sustainable. So all of this, these are some of the problems. Many countries still cannot provide glucometer strips and syringes free or near free to its citizens. I kind of understand why, but I lament the fact that we can't do that. People need to test. There's an increased demand on our countries. With the increased demand, our countries often face a challenge that the majority of the people who need to test, they can't afford. So as a physician, I can tell you that treating without testing and monitoring really doesn't make sense. You're not going to achieve what you want. You're basically shooting in the dark. And it's heartbreaking to hear the testimony that I read at the start, where my patients sometimes have to choose between food and glucose testing strips. A small percentage of persons living with diabetes access medical care via the public clinic, where all these benefits exist. But there's an even larger percentage, sometimes people query, that access medical care, diabetes and medical care, through a private clinic, where they will not get all of these benefits. And this, let me be a little more specific. So this was a testimonial from a colleague of mine in St. Kitts, and you have like almost 1/3 of the people just accessing the medical care in the public clinic, and the other 2/3 are going elsewhere. What is happening to those people? How are these people getting the care they need? We're not sure. Maybe they are so wealthy they can afford it. But then you know that if the country is providing all these free services, like, it would make more sense to access it there. There's still not enough involvement in our medical professionals. I know some of our medical professionals watching might probably go, "Oh man, I'm doing so much work already. What's wrong with you?" But I'm serious. We need to endorse the message of self-management. A pharmacy colleague of mine, when we were speaking, lamented on the fact that there are persons in our countries in 2021 who still cannot test their blood sugar. This is what the pharmacist friend of mine is saying, right? And that's because they just simply can't afford the strips. It's just too expensive. Right? They have to eat, right? They can't afford glucometers, and that shouldn't be. We can do something about it, can't we? He also cited that he found that pharmacists were often left out of some of those important conversations. Like, I don't want to put any blame on our group here, but pharmacists have to be involved in even this conversation. They have to be heavily involved everywhere, because pharmacists are the ones giving patients the medication. They spend most of the time with patients, whereas the doctor will see the patients once every 3, 4, 6 months, maybe once a year. The pharmacist will see them more often because they will not want to see the doctor, but they will go get their medication. And every time, that's an opportunity for enforcing that message, for educating and for helping. So there's still more we can do, I believe. It also has to be sustainable. Some life-saving technology is only available in developed countries. We spoke about this before. I think Dr. Hennis spoke about this also. Right? You have some technology that you cannot get, you just simply cannot get because it's just not affordable. Insulin is so expensive in some countries. And then you have countries that provide it for free, but then that's all they give you. Dr. Viora gave us a list there. SGLT2 inhibitors are not available, right? Other medications are not available, but you do have some of the basics. Some patients may not do very well on those, and you need other options. And the last thing I want to mention is insurance. I did speak about insurance the last time I was here. I don't want to talk a whole lot about it because it's so complex. But insurance, what can you do? What are you doing? You're not supporting people by not covering diabetes medication and diabetes supplies for people living with diabetes who are under your insurance. What is the point? So if you're going to cover them and take the premium from them, at least see how you could also cover those supplies. Glucometer strips, you can't cover a glucometer only once in the person's lifetime because everybody knows a glucometer will never last your lifetime. You can't cover just a few strips for people who need to test so often. You can't not cover diabetic shoes or other things. I mean, I'm just throwing things out there, but you have to think about prevention. And what are you doing to prevent that person from going from that large percentage of people with risk to that smaller percentage of people with complications who are taking up the largest portion of your what do you call it? I think you call it your risk pool. So you have to think about those things. Right. This is the bibliography that I used to put my presentation together. And I think it would be remiss of me not to mention that we, in the spirit of continuing to educate, our virtual Congress in 2021, we will have it on the 6th to 11th of December. And we have a wonderful Selection, we are really going to focus on complications, cardiovascular, eyes, foot neuropathy, and COVID-19. So we're hoping that people can access it. Go to our website, and we'll do the best to help. We can't stop. That's my conclusion. We can't stop. Silvana, we can't stop. We have to continue.
Yes.
No, we cannot. Because imagine it's so bad, and we've been doing so much work. Imagine how bad it would be if we stop. We have to continue. Thank you.
Thank you. Excellent presentation, Dr. Dorr, and for highlighting especially the challenges of cost and affordability, as well as access to services, and how we definitely need to do more. And we, again, are so grateful for the partnership that we have with IDF, with the civil society groups, with all the diabetes associations in our region to help make sure that together with governments, that the civil society and people living with diabetes are well represented so that we ensure that education, policies, services are really reflective of the needs of people living with diabetes and in the communities where they live. So I just want to thank all the presenters for such outstanding presentations and sharing your wealth of knowledge, and for inspiring us to really focus on diabetes prevention and control on this day that we're celebrating, the World Diabetes Day. And apologize to everybody for having gone a little bit longer than we had programmed, especially an apology to the translators for going longer. And to thank the translators for allowing us to be able to present in English and Spanish, and to thank everybody who has been behind the scenes from the PAHO Communications Department, from the Non-Communicable Disease Program, who have helped put this all together. And just to close off this session, I'm going to invite Dr. Anselm Hennis, our Department Director, to give us some parting words. Dr. Hennis, back to you.
Yes, thank you so much. Thank you, Silvana. Thank you to our presenters. Thank you to our participants. We've actually had as many as 620 people participating in this room with us today on this webinar for World Diabetes Day, dealing with increasing access to diabetes care in the region of the Americas. We've had a lot of food for thought. Excuse the pun, but really we've heard a lot about the critical importance of having diabetes firmly established in terms of NCD care at primary health care level, the first level of care. We've heard about the need for multidisciplinary approaches to facilitate and speed up early detection, appropriate care, which includes self-care. And we've also heard not just about the primary care level, but as in diabetes, the need for interacting with other levels of the healthcare system, secondary care and tertiary care. And you've heard about having examples in the countries in terms of having specialists being part of the process in terms of screening and detecting diabetes patients, as well as managing their care. We've heard about the importance of gestational diabetes, not a concept we speak, not a disease area that we speak a lot about in terms of our discussions, but a critical area that we also need to strengthen our approach to. We've heard about the importance of preventing complications. We've heard about the importance of information, data. We've heard about the relevance of registries. So there's so many issues that we've heard. And we, of course, heard about the challenge with technologies and access to insulin still 100 years after the discovery of insulin. We've heard about the innovations such as the heart's D module, and there's so many more things that we heard this morning. And I think the key message is there's so much more to do. We all have to continue to play a role to turn the tide on the diabetes epidemic. So again, thanks to all our presenters. I wish to acknowledge from Trinidad and Tobago, Dr. Abdul Hamid. I wish to acknowledge from Paraguay, Dr. Dora Oig. I wish to acknowledge Dr. Timotheus Dorr. And I also wish to acknowledge Dr. Douglas Villarroel for the work they're doing also in Bolivia and the sub-regions. So thanks to our participants, and let us all go forward to do our part to tackle diabetes and halt the rise and reduce the significant toll and loss to life and disability linked to diabetes. Thank you so much for participating. Have a good rest of the day. Thank you.
Thank you.